cardiac, part 2. Your objectives. All right, shock. Let's talk about some shocks for a little bit here. Now, if you look at all of the different signs and symptoms of the shocks, they are similar. So let's talk about some specific things that you're going to want to note down, okay? Hypovolemic shock. Hypovolemic shock, you're going to have the same signs and symptoms as severe dehydration. High pulse, high respiration rate, low blood pressure. Cardiogenic shock. We're going to be watching the kidneys. Cardiogenic shock, we're going to be watching the kidneys. They're going to be hypotensive as well, tachycardic as well. So watching the kidneys is going to be key for cardiogenic shock. Neurogenic shock, bradycardia, bradycardia, bradycardia. Bradycardia is a sign the patient's not doing well when they're in neurotic shock. Anaphylactic shock is the patient's going to have the urticaria. They could have difficulty breathing and coughing if their throat's swelling up. Septic shock. Septic shock, the patient's going to be hypotensive, tachycardic. They're going to be in fluid volume overload. When we're dealing with somebody in septic shock and we're looking at treatments for it, we're going to give O2. We're going to do normal saline boluses, norepinephrine cultures, blood, urine cultures, and then the antibiotic. So you titrate the O2, you infuse saline, you start the norepinephrine, do cultures, and then we go to antibiotics. So the fluids are first and then the pressors, which is pretty typical when we're treating anybody with low blood pressure. So this is just a breakdown of it to help you out a little bit more. So as you can see, these are the manifestations to all the different shocks. So they are pretty much the same, except for neuro. Neuro, the heart rate goes down. In neurogenic shock, the heart rate goes down. Everything else, the heart rate goes up. Cardiogenic shock, we talked about watching the creatinine levels, watching the BUN levels. This is all about what the kidneys are doing. The kidneys are a measurement to see how well the patient is doing. If the patient starts getting urine output less than 30 milliliters per hour, we need to intervene, possibly dialysis. Hemolytic shock. Hemolytic shock. We're going to give IV fluids and blood, RBCs. Hemolytic shock, we're going to get that blood going, but we're also going to get the blood bank going on getting the RBCs ready to go in. Because if you look at the majority of the causes, they all have something to do with bleeding. Don't really worry about distributive shock. All right, sepsis. So when we are talking about sepsis, sepsis is a disease process that if the patient's in the hospital, it should be caught. If the patient is out in the community with sepsis, well, they would probably have a work cut out for us. So if you have a patient come into the hospital and we believe that they're in sepsis, the things that we should do immediately for this patient and or us, because we don't want to get any of the buggies that the patient has, okay? We're going to put the patient under isolation contact. Anytime we go in, we should have a full eyewear, mask, gloves, and gown. The doctor is going to order lactic acid and blood cultures. The doctor is also going to order antibiotics and protonics. And because sepsis patients are very typically hypotensive and badly, we're back to IV fluids and medications like norepinephrine. One of the measurements we look for when we're treating sepsis patients is their urine output. If their urine output is going low, the patient is getting worse. So the signs and symptoms we look at for sepsis are an increased temperature, an increased heart rate, increased respiration rate, and we're watching those white blood cells to see if they're increasing also. All right, the different stages of shock, you don't really need to know the different progressive versus non-progressive. Multi-organ dysfunction syndrome, better known as multi-organ failure. This is when the organs start to lose their function ability. They can go into MODS, which is small clots that turn into something called DIC. Once the patient has gotten to MODS, it's going to be very difficult to get the patient back. So it is very much a strive to never let the patient get here. So sometimes it doesn't matter how well we do our job. The human body is not designed to last for forever. All right, treatments of shocks we kind of already talked about, but let's go over a couple of them just to make sure. So septic shock treatments, we're going to get the oxygen flowing. We're going to infuse normal saline. We're going to start norepinephrine, do cultures, and then do antibiotics. All right, over to the wild world of dysrhythmias. So now we're going to introduce a couple other dysrhythmias that you do not get covered in MedSurg 1. Here are the H's and T's. Again, you don't really need to know what these are for NCLEX purposes, but these are what we look at during a cardiac arrest. To try to fix the underlying cause, you fix the cardiac arrest. EKG lead placement, just if you need a refresher on it. How this heart actually is conducting the EKG. So let's talk about this a smidgen here about what these particular things mean. When it comes to the P wave, the PR interval, this is the arterial depolarization. Basically, this is when it relaxes. The R is the ventricular depolarization, and the R is what we see go up when there's an electrolyte imbalance, specifically potassium, but you can actually have the R wave go significantly up with a great deal. I'm sorry, not the R wave, the T wave. Ignore me, not the R wave, the T wave. The ventricular repolarization goes up when there's electrolyte imbalance. My apologies. All right, conducting through cardiac muscles, basic EKG aspects. Remember, we're doing mostly sight reading. On the NCLEX, they will not be having you measure EKG. So these are the ones that we're going to do for sight. Right. So normal sinus rhythm. Normal sinus rhythm between 60 and 100. The P, the QRS, and the T wave are all regular. And there is nothing to do further with this patient except continue to monitor as ordered. Sinus Brady. Sinus Brady is when the pulse drops below 60. The P wave, the QRS, and the T wave are all regular, but an unstable bradycardia patient is somebody whose blood pressure is also dropping, and they can get diaphoretic on you, and they can constantly pass out. The first line of defense for bradycardia is a medication called atropine, and then after that, we would put an external pacemaker on the patient until we figure out what the problem is or we get them into surgery to have a implanted pacemaker put in. Sinus tachycardia. Sinus tachycardia always comes from a different base. It's rarely ever fatal. Usually it's from exercise, which is stable, possibly anxiety, different types of drugs. If they have a fever, we give Tylenol. Serious caffeine use or stress. If the patient needs a pacemaker put in for sinus bradycardia, we want to make sure that the sling is on the arm after surgery, and we stress the importance of education that they do not raise their arms above the chest line. The patient raising their arms above the chest line could dislodge some of the pacer wires. And then they'd have to come back and we'd have to go back in and replant them. And it does happen. And then they start to get little shocks. The patient should never feel the pacemaker working. All right, atrial fibrillation, the most common abnormal rhythm you will ever see in our country, okay? And the big thing with this is they're going to be on Coumadin the rest of their life. So we're always teaching them the importance of holding pressure if they are bleeding, and the patient and the family to watch for signs of stroke. So if the patient all of a sudden is having slurred speech or no speech, or their one side of the face has drooped, this is a 911 call. Different heart blocks, we're not going to spend a whole bunch of time on the different heart blocks because you would absolutely have to measure them to absolutely know what heart block you're in. But let's go over them real quick. This won't be on the exam, and these are not on NCLEX, but we're just going to run through them, okay? First degree heart block is where the PR interval is greater than 0.2. So basically, it's just longer. There is no treatment for this. This patient is going to be stable. There's not going to be an issue. We're just going to continue to monitor as ordered. So second degree heart block, better known as type 1 Winky Bach, this is where there's a drop beat. Now the problem with this can also look like PAC, a lot of PACs, unless you measure it out. If the patient's stable though, we don't do anything. If they're stable. So if they're asymptomatic, the heart is functioning enough that we don't have to do much concern about it. Secondary heart block. Secondary heart block is going to be a little more assessment-wise. We're going to be watching this patient for any types of signs of lowering blood pressure, LOC decreasing, so level of consciousness decreasing. Now, these patients generally asymptomatic, but they can get symptomatic pretty darn fast and go into something called third degree heart block. Third degree heart block, we typically pace them so an external pacemaker. And this could be a sign that there has been a past heart attack. It also could be a sign that the patient is currently having blockages. So a third-degree heart block is going to get a lot of attention fast from medical personnel. Brundle-Blanchbach, we don't do anything with this. It's completely asymptomatic, and we just continue to monitor. All right, fun one, SVT, supraventricular tachycardia. This is one of the medications very similar to VTAC, where if the patient's stable, we're going to give them adenosine, which stops the heart temporarily. If we absolutely need to, if the adenosine is not working or the patient is becoming unstable, this is a cardioversion patient. So we are going to shock them out of it with a low voltage shock. Premature ventricular contractions, better known as PVCs. If the patient gets a lot of them, we might be worried about VTAC coming on, but typically a patient could get one or two. We all get one or two in an hour in a day, and it doesn't, we just continue to monitor as normal. Nothing's going on. VTAC. VTAC, there's a lot of things that we can do. This patient very often is going to get lidocaine. And then we're going to measure to see if the patient went into normal sinus rhythm, how long they can go into normal sinus rhythm. We can also give this patient adenosine. And we can also cardiovert this patient if need be. VFib. VFib. We're going to VFib is one of the very actual rhythms that we actually do immediately defibrillate for, okay? We also can give the canes for this, right? We can give amiodarone, lidocaine, and procamin. Those are 3 medications that you're going to see a lot with VFib. We give epi during a code situation to get the little bit of rhythm that we have speeding up so we have something to treat. If you notice, epinephrine is pretty much involved in every single code out there. This is what a pace rhythm looks like. A patient has a pacemaker, everything's fine. We're just going to continue to monitor as normal. Different cardioversion versus defibrillation. You do not need to know the difference of these. They're just there if you're curious. If you go into any type of cardiac ICU, ER, OR setting, you're going to go through extensive telemetry and cardiac training. So NCLEX won't jump with these. So just a different overview. So signs, symptoms of and treatment of low and high heart rate. Low heart rate, again, anything below 60. Weak pulse, patient's dizzy, altered LOC. Altered LOC is always a concern. Patient had surgery, had a CABG, had a cath. Altered LOC is always going to be a concern. Like I said, usually the first treatment is atropine, and then we go to pacing. Faster heart rate, heart palpitations, the patient can be short of breath and dizzy because the heart is moving so fast. Treatment is medications to slow the heart down, so like adenosine, or cardioverting the patient.